Hello, everyone. Thank you for joining. My name is James Iwaz, and I'm a non-invasive cardiologist at the VA Long Beach in California. And today I'll be reviewing the basics of scanning in regards to cardiac CT. So I wanted to thank you all for joining and thank SCCT for having me. I have no disclosures. This talk overall is a general broad overview of cardiac CT. We'll be briefly reviewing the common indications for cardiac CT, as well as the basics of image acquisition and just mentioning ECG gating. You'll be hearing more about these topics in much more detail in the talks to follow. So starting off, what is coronary CT angiography, also known as cardiac CT? Our goal is to try to take a complicated 3D structure, such as the heart, that's constantly moving, and to obtain 2D images of the structure and to be able to see smaller structures in detail, such as the coronary arteries. The reason we do this is it's another tool in our toolkit that potentially can offer less radiation than other similar testing options, such as nuclear stress testing or invasive coronary angiography, which in and of itself is a procedure, so has its risks, whereas cardiac CT is non-invasive. And so for the right patient population, this would be a very useful potential test to offer them. As I just touched upon, there are many challenges in imaging the heart. The heart is a very complex structure. You have coronary arteries that generally don't go in a straight direction. They curve, they give off branches. The coronary arteries, compared to the rest of the body, are very small. We're talking about a few millimeters in diameter. And we're trying to create a still image of a rapidly moving structure. And the heart is moving in multiple ways, right? It's moving in the longitudinal direction, in the transverse direction, and torsional as well. And so it's rapidly moving, and we need to try to get accurate images. So it's a challenge. And how do we do this? We use something called ECG gating, and you'll hear more about this later. But basically, this pinwheel picture on the right is just a common everyday example. But if you look on the right, the pinwheel is in motion and it's very blurry. If you look on the left, the pinwheel is actually still in motion here, but we've gotten a very crisp picture. And so it's very clear. It actually looks like the pinwheel is not moving at all. And that's what we're trying to accomplish with imaging the heart. We want to get clear, crisp images with minimal to no motion or blur. What are the most common reasons for cardiac CT? The most common reason is chest pain, and this can be further categorized into stable chest pain or acute coronary syndrome. Stable chest pain, these are usually outpatients. It can be either patients with no history of coronary artery disease or CAD, or patients with known CAD. And the recent guidelines that have come out have put CT more at the forefront of imaging modality in these patients, even with people with known CAD, depending on the location of the disease and how severe it is. So it's a really good tool for many patients, not everyone, but many patients. Another option or common indication is for acute coronary syndrome rule out. So these are usually people that come to the hospital, the ER, they're here with chest pain or shortness of breath, they get troponins, those are negative, and they want to send the patient home or rule out cardiac condition. So they want to get ischemic evaluation, and cardiac CT is a potential option. Again, depending on the patient characteristics and if they're able to tolerate the CT scan. Another option is for a TAVR workup. TAVR is a percutaneous aortic valve replacement, usually transfemoral, but there are other access sites as well. And for this procedure, the interventional cardiologist will almost always want a cardiac CT for several reasons. One is to size the aortic annulus to make sure that they're picking the biggest valve that's safely possible. Another is to make sure that the coronary ostia are not too close to where they're going to put the valve, or not too close to the base of the aortic annulus. And they also want to look at the access sites. So like the femoral arteries, for example, to see, is there a lot of plaque there, or are they able to fit their equipment through that vessel? Another example is prior to AFib cases. So our electrophysiologists, when they do AFib ablations, will essentially ablate around the pulmonary veins, called pulmonary vein isolation. Most commonly, there are 4 pulmonary veins, 2 on the left, 2 on the right. However, there are patients, and it's not uncommon, it's a normal variant to have 5 pulmonary veins. Some people have 3. So there's a little bit of variability with the numbers of pulmonary veins. And so if you are doing an ablation and you ablate 4, but the patient has 5 pulmonary veins, then you have an incomplete ablation, and that patient has a higher risk to have recurrence of their AFib because you didn't completely isolate all the pulmonary veins. So that's another strong indication for CT. And then congenital heart disease is another example. These patients have complex anatomy, and sometimes an ultrasound or an echo alone is not enough to really delineate what's going on. And so a CT can be used to further help look at the anatomy and see what's going on. A really big takeaway is that cardiac CT has a high sensitivity and negative predictive value for obstructive coronary artery disease. This table is from the Journal of American College of Cardiology. Essentially, it's saying if you have a negative or normal cardiac CT, which is the green boxes on the left of the slide here, that essentially no further cardiac workup is needed for CAD, and you can then do your other evaluation for chest pain. If your CT is ambiguous or abnormal, then you may have to do further testing. But basically what it's saying is if it's negative, you're essentially ruling out obstructive CAD. I'll briefly touch upon some technical aspects of how a CT scanner works. You can think of a CT scanner as a camera. I mean, that's essentially what it is, just like our everyday cameras. So you have the X-ray source, which is like, you can think of it like the camera lens. And the X-ray source is sending X-rays through the patient, where the patient's in the middle here in the circular area. And there are detectors on the other side. The detectors you could think of as film. On the left here is a single slice detector. So that's one detector for the area that you're evaluating in the Z-axis coverage, which is from head to toe. So it's just one detector. On the right is multi-slice detector. So we have multiple small detectors in that same Z-axis coverage as a single slice on the left here. And for the benefit of this is it increases your spatial resolution. And as you recall, cardiac structures are relatively small compared to the rest of the body, especially the coronary arteries. And so we really want to maximize our spatial resolution. So for cardiac studies, we will almost always use a multi-slice CT scanner, but like similar to what's pictured on the right. Now to review our coronary anatomy. So there are 2 main coronary arteries that come off of the aortic root. There's a left main, which comes off of the left coronary cusp, pictured right here. The left main normally bifurcates into the left anterior descending artery, which courses in the interventricular groove in between the RV and the LV on the anterior surface of the heart. And then the left circumflex, which courses in between the left atrium and the left ventricle and wraps around the back of the heart, as you can see here. Then there's the right coronary artery that comes off of the right coronary cusp that generally supplies the right ventricle as well as the inferior walls of the left ventricle. There's also a ramus intermedius. This is a normal variant. This vessel can come off of the left main. So in this case, the left main would trifurcate, and this ramus intermedius generally supplies the lateral wall of the left ventricle. Now, in terms of dominance, that's something that's important to discuss. So there's a vessel called the posterior descending artery. This vessel supplies, you can think of the opposite side of the heart as the LAD. So it supplies the posterior or inferior wall of the heart between the RV and the LV, just essentially opposite to the LAD. Now, this vessel in 80% of 90% of patients comes off of the right coronary artery. In this case, it would be that patient would have right dominance. However, in a smaller portion of patients, about 10 to 20%, this vessel will come off of the circumflex, and this system will be called a left dominant coronary system. And that's just important to know. If you have a left dominant system, then that means that your RCA will probably be fairly small in diameter, since the left side, left main, left LAD circumflex is supplying most of the heart. And so it just gives you an idea of what to expect, and also is important to note in your reports. Now, to briefly mention the CT attenuation, as I mentioned, the detector is essentially measuring how many X-rays get through, and the computer software then takes that and makes an image. And how does it do this? Well, it assigns attenuation values relative to water. So water will be 0. So that'll be this kind of shade of gray. And then a metal will be over 500, bone around 300. Metal will be bright white. Air will be negative 1,000, will be black. That's why the lungs look black on a CT scan. And then fat will be around negative 50. And so this is how the computer software assigns varying shades of gray to the scan. And that's how we can see the image on our computer screens. So the general workflow is really important. What do we do at our facility? We give 50 milligrams of metoprolol tartrate 2 hours prior to the scan if the patient's heart rate's over 60. The patient shows up, we make sure they have adequate venous access, so they get a right 18 gauge IV in the right antecubital fossa. You don't want it to be much smaller than 18 gauge because cardiac CT is high flow, so we're injecting a lot of contrast very quickly. And if you have a smaller IV, you run the risk of the IV blowing and causing extravasation into the patient's subcutaneous tissue, and we want to avoid that if possible. It's not comfortable for the patient, and also you won't be able to scan the patient. Then if your heart rate is still elevated, you can give IV beta blocker, and this is where preparation is key. If you have to give IV beta blocker, that'll really take a good chunk of time away from you, because you'll have to sit there, or whichever provider is giving the medication will have to push the beta blocker or whatever agent you're giving and monitor the heart rate and the vital signs, then give more if needed. And it's sometimes I've been down there in radiology for 45 minutes doing this. And so if you can give enough beta blocker ahead of time, you can try to minimize this as much as possible. Another key thing is to practice breath holds with the patient. The patient will be holding their breath during the scan at multiple points in time. And you want to have them try to do it in a similar fashion, and not take a huge breath one time and like a small breath in other time, because that could result in like stitch artifact if you're doing different slices, or it can result in respiratory motion if the patient doesn't know to hold their breath for long enough. You want to review medications with them, see what medications they're on. You give sublingual nitroglycerin as part of the study. So if they're on any phosphodiesterase inhibitors such as sildenafil, you'll want to know that, because it's a contraindication to give nitro. You then do a scalp film, which is essentially an X-ray to help determine your coverage. You get the non-contrast study, which is the calcium score. You adjust the field of view if needed. You give sublingual nitro, you give contrast. We use tracking bolus at our facility, and you'll hear more about that in later talks. And then you do the CTA portion of the test. So for image acquisition, we get the scalp film. This is, like I mentioned, a chest X-ray essentially, and you can adjust the coverage. And so you want to start the Z-axis coverage. So remember, Z-axis is head to toe. You want to start it around the level of the carina. So that's right about here. And then you want to end about 2 centimeters below the diaphragm, because the heart does dip a little bit under what we're seeing as the dome of the diaphragm. And you want to also move the box more anterior off of the spine, just to minimize any attenuation artifact from the spine. Then we obtain the calcium score. So this is a non-contrast gated study, ECG gated study, and we obtain it at specific parameters as shown here. Afterwards, you then can calculate an Atkinson score. So, and this software is Vitria. It highlights the calcium in purple. So you just go and basically circle this, and then you go through each slice. It'll then calculate an Atkinson score for you. That's a number, right? So if your calcium score is 100, it's good to know, but it also is important to try to normalize it based on the patient's age and gender. Coronary artery disease is a disease of age, so more often in older patients, and also more often in men. And so a calcium score of 100 in a 40-year-old man or 40-year-old woman is going to be very abnormal compared to a calcium score of 100 in an 80-year-old patient. So that's important to know. And the MESA database is one tool that you can use to help give you a percentage of where the patient falls compared to their age and gender. You can then, at this point, abort or adjust the z-axis coverage as needed. You then do the reconstruction. Again, you do contrast breath hold, and you obtain these images. So you get the axial data. You then can do 3D volume rendering, a curved multiplanar reformation, and maximum intensity projections. I'll show you some examples briefly. Here's the axial data. Here's the curved MPR, which you could actually rotate in the software in real time and look at the vessel. This is just a still image, just showing you an example. And then here's the 3D volume rendering. Again, not very useful for looking in the lumen of the vessel, but just gives you a broad overview of the anatomy, the coronaries, and whatnot. So in summary, cardiac CT has a high sensitivity and negative predictive value for obstructive CAD. That means that if your cardiac CT is completely negative, you have a pretty good odds of ruling out obstructive CAD. Cardiac CT can also offer lower radiation compared to other options like nuclear stress testing and coronary angiography. And prospective ECG is really important here, which you'll hear more about later. Patient preparation is also important. Again, heart rate control, though given the improvement in CT scanners, there's a little bit more leeway with what heart rates you can scan at, but still is important to get the heart rate under good control. Generally, you want to be under 65 beats per minute. And you want to obtain IV access as well, as I mentioned, and interpretation requires integrating the calcium score with the CTA as well as the clinical picture. So it's an important tool. It's important to know which patient populations you can use this in, and it's a great option for a lot of patients. So thank you so much for your time, and I hope this was helpful.